thank you very much. Actually, the two previous speakers actually did a really nice job, considering that what a broad thing. So it's such a beautiful day outside. I mean, I'm happy to just sort of call it a day and say that we did this. And you can get the CME credits, right? If we just go on out, because we were asking, could we like raise the shades or something, because it is so beautiful out there. This is actually my first time up here, though. There are two things about that. One is that, wow, it really is beautiful up here. I understand why people live here. Second is that we do have patients who have to come down to Los Angeles, and I really appreciate how long it takes to drive back and forth. And also that how fortunate you are to have a multidisciplinary team that can take care of and give excellent, superb care to really 95% of the patients that, and really take care of their needs. And I think as the two previous speakers said, Doctors DiCarlo and Spillane said, is that this is a field that really requires not just oncologists, but multiple different types of specialists. And that you're fortunate to have basically enough people and enough of a medical center really to do that. Because once you hit that sort of critical point, then that's when patients really get the best care. And then when you get sort of beyond that, that's when the patients have to do the 3.5-hour drive. And as I said, I'm more appreciative now having just done that and many of them are doing it during traffic time. So actually, not having seen the slides, there is going to be some overlap, but I think I'm going to try to explain why I'm so excited about this. So I'm originally a gastroenterologist, which means that we wear ties, right? And so that's what gastroenterologists do. I came in here and I was like, oh my gosh, I am the only person wearing a tie here. And I was actually debating, because I would rather not wear a tie. But then you came in with the tie and a suit, and I was like so happy. And so but anyway, But really what I'm here to talk about is about the revolution that's happening in cancer therapy. So first, to say how, I can explain things to all different levels of people. I know that at least 2 people here are oncologists. How many people are medical oncologists? Okay, guilty. All right, and there's another medical oncologist over there, 3. Okay, how many people here are internists or primary care physicians? Okay. And how many people are mid-level providers then? How about that? A lot. We run on, not on coffee, but because our mid-level providers drink a lot of coffee. And so which is true, and in fact the nurse practitioner who works with me, who basically makes my life possible in the clinic, son is actually here in San Luis Obispo, and so she's driving up. She also understood that I should probably not drive up and back in the same day. And then how many people here are survivors or lay people? Okay. All right, so I'll try to make this sort of at a level where everyone can understand. Because I always said that if you can't explain it, then you probably don't really understand it very well. And there's lots that I don't understand, but I'll do the best that I can. But really, I'm so excited about being a GI oncologist in 2018. So I started as a medical oncologist. I started as a gastroenterologist actually in the late 80s. And what I did is that I was at Northwestern, and then I did an extra year at the University of Chicago. I was waiting for my wife to finish her fellowship, and her first fellowship. And I heard this person named Dennis Slayman give a talk up in Milwaukee about these things called oncogenes. And I said, that is really interesting. And so even though I'm a GI, I'm going into GI because that's the most important part of the body, that I said that that's what I want to work with. And Dennis was kind enough to take me in his lab, which then he gave me about this much lab space, because that was before he was famous. And so for those of you who don't know, Dennis Slayman is the person who showed that HER2 was important in breast cancer, helped basically develop Herceptin, as has been mentioned before, and ended up getting a made-for-TV movie made after him, which I guess that says something at least. And so, but he just, as I said, my goal is also to be played by Harry Connick Jr. at some point in time. And so but anyway, I thought that was really interesting. And most of my life and most of my professional life has been working with targeted therapies. And for those of us who've been in the field for a long time, targeted therapies were going to turn cancer into a chronic disease. Okay, and that was the hype and the hope And that included basically drugs that block signals to grow, like Herceptin or trastuzumab. I ran most of the panitumumab US trials. That's a drug that's used in colorectal cancer in RAS wild type, no mutation patients, as was pointed out. And so we also worked with drugs that block the growth of blood vessels. They're called anti-angiogenics. It was on the cover. There used to be this magazine called Time Magazine. I think it is still out there, but that was the cover, and saying, are we going to make this into a chronic disease? And the answer was, yes, we help people. Yes, we spent a huge, and still spend a huge amount of money, but we probably don't cure a lot of people. Probably the place where the biggest cure has been in breast cancer, with adding these signal transduction inhibitors like Herceptin. Cures an increasing number of women, and that's probably the only place where we've led to long-term cure. So being at UCLA, there are lots of good people there, and one of them is named Jim Economo, who's a surgeon, and though has been doing immunotherapy since, gosh, for 20, 30, 40 years now, and trained a bright young guy named Tony Rebus, who I'll mention a number of times. And I used to go to their yearly immunotherapy talks, and they were mostly melanoma doctors, and they would use terms that I didn't understand and talk about tetramer assays and MART and MAGE. The oncologists may have heard of some of these, and basically none of it really seemed to be that important. And so then in fact, I would tell the fellows who would train with me, as I said, wake me up when immunotherapy becomes important. Because I would go, well, the alarm went off about 5 years ago, and mostly what I'm going to talk about is immunotherapy. Why is immunotherapy important? And the reason is because I think was alluded to by both the previous speakers, is not only can it help some people, but when those people are helped, they tend to be helped for a really long time. And that's really, in the end of the day, that's what we're talking about. We're not talking about small increases in survival. We're not talking about being on treatment for a few more months. We're talking about if you really respond, you really do respond. Now, the problem is that despite what the people selling nostrums at GNC says for things that boost your immune system, the immune system is actually really complicated. And we'll talk a little bit about that. And we're really sort of at the shore of the sea right now with some of the drugs that have already been presented. I'm going to go over some of the same data, but maybe kind of look at it slightly differently. But what I'm also going to talk about is sort of where do we go from here. So we help a small percentage of people now. We didn't help them before. They were unhelpable, and if that's a word. And so but now we have the chance, hopefully, to help a lot more people. And so this is really, the revolution has come. It didn't come quite the way that I thought it was going to come. Does this actually work? There, I guess. Okay. But now the time has come to join the revolution, at least for GI. We've been really looking at our colleagues in other diseases where the revolution has been. And unfortunately, since about a third of all cancers worldwide are GI, actually the second and third most common causes of cancer death are GI, it really is time for GI to join the revolution. So I'm going to talk a little bit, since there are a lot of people here who are not oncologists. The three oncologists can fall asleep at this point, and well-deserved. And so let's talk a little bit about genetics. And these are things that people get really confused. And cancer is a genetic disease. By definition, if a cell did not have abnormal, or mutations or abnormal genes and abnormal signaling, abnormal programming, then you would never meet your oncologist, because otherwise those cells would listen, they would not grow, they would not turn into tumors. So all cancers have mutations by definition. But what gets confusing is that there are also patients who have mutations, and those are called germline mutations, as opposed to the cancer mutation, which is sometimes called somatic mutations. The germline mutations are important, and they've been mentioned to us. Actually, two out of these three have already been mentioned, and these are things that cause predisposition to the tumor. On the other hand, I'm also going to talk about the genetics of the tumor itself. So germline versus somatic. Lynch syndrome and some of these genetic alterations actually overlap when it comes to treatment. Lynch syndrome, which predisposes to colon, gastric, uterine, and ovary, is also that has a predisposition. One of about 4 or 5 different genes can cause that predisposition. BRCA, which is mostly known for breast and ovarian cancer. Also overlaps, as has been mentioned, in pancreatic cancer. There's a really rare condition called hereditary diffuse gastric cancer syndrome, which is an E-cadherin or CDH1 mutation, and those patients have a 100% chance of getting gastric cancer at an early age. So this is actually very important, and one of the things, the reasons that this is also important is that the person who first described Lynch syndrome, Aldrich Worthen, anyway, said, and this was in the 1890s, said Americans don't know their family history and physicians don't ask what little they do know, and that hasn't changed so much, unfortunately. And now we're in the 2000 teens. There are other problems. People don't know their family history. They may be adopted. People don't have 10 kids usually like they did back in the 1880s, 1890s, but it's still important. And we'll talk about the genetics of the tumor. So let's talk a little bit about Lynch syndrome. I know this was talked about. This is actually about 2 to 3% of colon cancers. They're early onset. They tend to be right-sided, like the discussion that Dr. Spillane had about the right side. The right side is actually embryologically different. It's mid-gut as opposed to hindgut. Autosomal dominant means if your parents have it, if one of your parents has it, you have a 50% chance of getting. We talked about gastric, ovarian, uterine. And the risk is fairly high. And the reason this overlaps with the revolution is because these patients have lots of alterations in they get lots of mutations. So basically what these genes do is they fix errors. These are the spell checker genes. Every time a cell divides, as politicians will say, mistakes are made. And so then what happens is that the job of these genes, this sort of complex of genes, is to fix those. But if they're broken, then mutations build up, and it is those mutations in the tumor that hurts the patient. Okay, so it also was mentioned there's another syndrome called familial polyposis, which I take care of those patients, but I'm not really going to talk about Lynch syndrome patients. As you get older, your risk of cancer gets up fairly high. BRCA1 is also important. It's about 1 in 400 Americans actually carry either BRCA1 or BRCA tumor. They have a high risk of breast and ovarian cancers. They also they're involved in another type of double-stranded repair. They're what are called Ashkenazi Jews, like I am, and which are Jews of European descent. They have about 1 in 40 chance of being a carrier. And my family actually is affected by this. And so the one thing I will say is that if someone has Ashkenazi Jewish heritage, that the test costs about $100 now. There's no reason on God's green earth not to be tested, particularly as a woman. Okay? Just a pitch. In GI, that's not why you came here to hear me, but in GI, as was mentioned, there is an increased risk of pancreatic cancers. Because of the breast cancer data has already been mentioned, there is a class of drugs that are called PARP inhibitors. Basically, these cancer cells already have one mechanism to repair DNA mutations or DNA alterations that's hurt. PARP inhibitors or certain types of chemotherapy like platins hurt another type, and that's called synthetic lethal, meaning that one by itself doesn't hurt, but if you knock both of them out, sort of like someone doing push-ups, you knock both arms out, they fall down. Actually, probably not one arm out, they fall down. But anyway, that's the idea. And these are approved, and there are trials, Eileen O'Reilly and Memorial Sloan Kettering and others, and we can get these drugs for most if someone has it. Once again, unfortunately, these are not curative, though there may be some overlap between PARP inhibitors. It's really interesting with they actually upregulate PD-L1. So now we said genetics in the tumor. Most cancers are sporadic, meaning that you don't have a clear family history with them. Not that you shouldn't look for a family history. The other thing that happens is that there's some cancers like breast cancer that are just common, especially small breast cancers or not very aggressive prostate cancers that are just important and probably aren't really related to most of these. So we do tests on the tumor in GI. As has been mentioned, we look for RAS, RAF, HER2, MSI. We'll talk about those in just a little bit. These actually have to do with what drugs to use or not use, and this has to do with immunotherapy. Upper GI has already been talked about. I did want to put in something, if it's okay to fit this in, about next generation sequencing, since we were talking about this. Now, it sounds so cool when you say next generation. I was thinking about what happens 10 years from now when there's something else. And so, like next generation sequencing or beyond next generation sequencing. And these are sometimes called Foundation 1. There are a number of companies that do this. There are actually an increasing number of companies that do this. Foundation 1 or Caris. And the reason that we can do this is something called Moore's Law. Moore's Law has to do with that saying that with time, the cost of computing goes down. Actually, you need computing to do sequencing. So that's part of this genetics revolution that laid the foundation for the immunotherapy revolution. But what you can see is that sequencing is going way, way down. This actually cuts off at 2014. But to do these actually becomes cheaper and cheaper. So you can actually get the genetics of you or the tumor done at decreasing costs. Problem is we get all this information, we don't know what to do with this. And this is actually a typical the oncologists here know this very well and dread this because the problem is that, so this happens to be a company called Foundation One. The others are about the same. This is not an ad for them. I probably should have actually blocked that off. Please forgive me, CME gods. And so but anyway, so what you end up with is they do about 500 tests on the tumor. And what they're looking for are what are called actionable mutations. So for example, in colon cancer, as was mentioned, that RAS is found in about 50%, RAS mutation is found about 50%. It doesn't, it tells me one thing what not to do, but it actually doesn't tell me what to do. And in that way, it's somewhat actionable. Their P53, for example, is also found, that's a better example, in about half of colorectal cancers. It doesn't tell me what to do. And the problem is that you'll see this thing over here, but most of the time, these are not actionable. I'm not saying that you shouldn't do them, because occasionally we do find rare things, like BRCA mutations. Or in particular, we'll talk more about microsatellite instability or deficient, also known as deficient DNA mismatch repair. Those are the ones that are really sensitive to immunotherapy. But so we do this, but we're not really certain how, to interpret most of them. So this is the whole question. Oh, the other question is that sometimes you'll find a germline mutation in there. For example, a patient who has a BRCA mutation or has a gene that says they have lots of mutations may actually have Lynch syndrome or BRCA. So it's important to have genetics available also to refer those patients. They are getting more and more paid, but the other question is that they're not really particularly standardized. Different companies do different things. Now, the main thing I wanted to talk about today was immunotherapy. And so, because that's what, I have patients, we were just talking about this, who come in who have we have really interesting trials for. They said, but Dr. Hecht, talk to me about immunotherapy. I see this on TV. And that is really the revolution, but I just want to remind people it isn't everything, and things that help patients, whether it's immunotherapy or not, are things that help patients. But I am going to spend most of the time talking about immunotherapy. So I put this in because I wasn't certain exactly necessarily the level. So once again, the oncologist can fall asleep at this point. But why do we have an immune system? If you don't have an immune system, you're actually in big trouble. You live in a bubble. You're one of those bubble kids. And it allows us to live in a really dirty, nasty world with things that would be happy to invade us and to take advantage of all the fat that I have. And so basically, the immune system exists to eliminate invaders. And there are different parts of the immune system because really what we've most of the invaders that we have to worry about are either bacterial or viral. And if you don't keep your immune system in check, then you're in a different talk with different CME about autoimmune diseases, which can be horrible and, and deadly. And so therefore, this is something that's over the last billion years has evolved to really be, on one hand, kept in check. On the other hand is that our ancestors that were not very good at getting rid of bacterial and viral invaders did not leave children and are not really our ancestors. So that's why this is really important. Now the problem is that in a patient who has metastatic disease, who shows up with metastatic disease, by definition their immune system has failed. And so, because otherwise they wouldn't have metastatic disease. This would have been recognized as something that's foreign. But the problem, of course, is that cancer comes from you. Therefore, it is not very foreign. But the interesting thing is that our immune system is actually designed to kill things that are sort of like that. And the things that are sort of like you, bacteria are really not like you in general, unless there are some intracellular pathogens. But the things that are like you but are really dangerous are actually virally infected cells. And because they are carrying around their viral load and they can kill you, yet those cells themselves come from you. So the immune system has to be able to identify those and yet be able to kill them without killing the normal cells. And this I actually found, I was thinking about this, said, you know, we talk so much about this, I just wanted something that was really simple. And the two ways to look at it is what's called the innate immune system. And the innate immune system is the immune system that's triggered, ready to go. All right, so that if I have a cut, let's say I'm going to see the elephant seals, and I fall down and I cut myself on rocks covered with elephant seal excrement. Okay, so anyway, so my innate immune system is there to make certain that I don't end up with a rip-roaring infection. Okay, it doesn't have to recognize those bacteria necessarily, know exactly what those bacteria are. It just knows that they're bacteria. Some of them are mechanical things like having skin and being able to heal, but that's the innate immune system that kicks in really rapidly. Then there's what's called the adaptive immune system, and these are the T cells that you keep hearing about. These are things that, as well as B cells, that see something that's abnormal, and it takes a while for them to realize that basically they have to be turned on and to make effectors, whether they're antibodies or whether they're killing T cells, to go ahead and attack something. That's why when you're vaccinated, for example, you don't get immunity immediately. The other thing that's really important is that these actually work really closely together, and that basically you have to stimulate the immune system in order to turn on the adaptive immune system. And that's a lot of what I'm going to talk about. That critical thing, that's why I wanted to show this. Because just tickling the, because really what we've been doing is just been tickling the adaptive immune system. And as was pointed out by the previous speakers, is that they help some patients, but not only a minority of patients, unfortunately. I mean, it's wonderful. When those people are helped, it is a miracle. And I don't use that word lightly, but it really, truly is a miracle. But unfortunately, it's miraculous, meaning that not most patients aren't helped. So this has actually already been discussed, which is the whole idea of checkpoint inhibitors. And I'm going to actually say this again just because it is so important, which is that there are T cells that are out there that recognize antigens. Antigens means basically signals like proteins or things like that. And most of the time, those T cells that want to go and hurt things and want to kill things are actually kept in check. And the things that keep them in check are called checkpoints. And because it's so important, there are a huge number of these checkpoints. And this is actually from the antigen-presenting cell, a dendritic cell, or it could be a tumor cell. This is actually the T cell. And at one time I could make this joke, but most people don't remember it anymore. But most of the time what these checkpoints are doing is saying, and the tumor will hijack them and say, these are not the cells that you are looking for. And so saying that we are normal, leave us alone. And so what happens is that you have to have T cells that are already recognizing something is wrong. They have to be there. And then if they're turned off, turning off the turning off ends up getting those miraculous results that have been seen and already talked about. Does that make sense, or should I explain it again? You're turning off the turning off. Now, that's simple. And so now melanoma has always been kind of the poster child for immunotherapy. So even before these drugs, there were drugs like interferon, high-dose IL-2, which I did as a fellow. And so these are some of these are toxic drugs, and also even sometimes all by themselves. For whatever reason, melanoma really, really is an immunogenic cancer. And so the first trials, in fact, Tony Rebus, who runs our Parker Institute for Cancer Immunotherapy, or PICE, one of a number around the country, and is really a world-famous immunotherapist. This is some early data from melanoma. The drugs, so these are the drugs you see on TV. This is pembrolizumab, or Keytruda, versus nivolumab, or Opdivo. These are both PD-1 inhibitors, so they go back. What they do is they block this turning off, showing one, this is versus chemotherapy. But basically, there are two things that are important. This is, for those of you that don't actually live and breathe this is what's called a Kaplan-Meier curve. So what happens is that everyone starts out alive or not having their tumor worse at the very beginning at 100%. This axis is time going this way. And what you can see, and as was pointed out before, standard treatments go down to 0. That means everyone dies. Okay, that's a bad thing. Okay, what you can see here is that some people die, which is still a really bad thing. But also what happens, this is sometimes called a plateau or tail of the curve, which is a really good thing. So this means that some of these patients, we don't use the word cure yet, but are doing well for a really long time. And in fact, that's the group that we have the longest data on, and they've been taken off their medicines. That sounds kind of strange, taken off their meds. And so but anyway, but they're taking off these PD-1 inhibitors, and they still are doing well, meaning the immune system has been educated to attack the tumor. Whether it's all gone or not, it's keeping it in check long term. Okay, and then the next question was, well, melanoma is not that common. It's a bad, horrible disease. But what about lung cancer, which is the most common cause of cancer death? Eddie Guerin, who's at UCLA and has run trials with y'all as well, you had these open, actually was the first to show, this is another New England Journal of Medicine article, showing that patients with non-small cell lung cancer, which is the vast majority of lung cancer, these patients who got a PD-1 inhibitor, in this case pembrolizumab or Keytruda, that once again, this flattening of the curve, basically these people are doing well for a long period of time. This is a biomarker which was mentioned called PD-L1. I think it's important in lung cancer. I'm not so certain it's important in other cancers as well. That's saying, we'll get into that a little bit later. So what about checkpoint inhibitors in GI cancers? We have the good, which has been mentioned, which is, I guess Clint Eastwood is close to here. Whether you agree with him or not, that's a different discussion. But it works better in Los Angeles than the Central Coast. And so the slide, I didn't realize that. I hadn't thought about that. Anyway, which are the MSI tumors that have already been mentioned by both the previous speakers. They're the ones who do really, really well. They're the bad that we know they don't work, which is 97% of colon cancers, pancreas. And then there's the ones where it's kind of in the middle, which is of the upper GI tract. So I think has already been mentioned is that why are those T cells interested in the tumor? They may be kept away and told to turn off, but they have to be, they have to be interested at first. And the thing that probably interests them is that there are a lot of mutations. And some tumors have a lot of mutations. And some tumors don't have a lot of mutations. And this is a famous curve that's always shown in all these. And basically, the ones where it seems to work, these are different types. You may or may not be able to see this, different types of tumor. These are the ones that have lots and lots of mutations as you go up. So if you look, some pediatric cancers and things like that actually have very few mutations. Pancreas tends to have very few mutations. On the other hand, there are exceptions to this where there's something like usually virally induced cancers also have lots of T cells sniffing around that just need to be unleashed. But the ones that we look at are esophagus, stomach, lung, and melanoma perhaps having the most. This is sometimes called tumor mutational burden, and you'll get that on your next generation sequencing. It's unclear by itself what it means. In lung cancer, actually, it seems to mean an awful lot. So does it really matter? These are actually some, this was just published about 2 weeks ago. In fact, I was at the talk. It was published at AACR last week, I guess. That was published last week, showing that patients who had a high tumor mutational burden, in other words, lots of mutations, so lots of T cells interested, sniffing around, tended to do better than those that didn't. And these are on these are people on immunotherapy. So what about microsatellite instability? That's a fancy old term. It's also called deficient DNA mismatch repair, but the key thing is they have lots of mutations, lots and lots and lots. Sometimes it's called hypermutability. That happens in those patients with Lynch syndrome that I talked about. It's about 3% of colorectal cancer patients. They tend to be right-sided women, right-sided cancers, women. And so it's also not infrequent in upper GI cancers, as has been mentioned. Pancreas, wow, you're lucky. We always are looking for those, but it's probably less than 1%. And so, actually my colleague, Dr. Weinberg, had a wonderful patient on a combination trial of I think it was nivolumab plus another immunotherapy, and then they found out the patient was MSI, and it turned out it was probably all due to this. These people have really good responses, and I'm going to show some of the same slides, but basically this is from Zheng Li's. We were actually supposed to be part of this trial, but it was too expensive. Believe it or not, we would have lost $7,000 a patient, so my people said, no thank you. But anyway, it's a shame, because it was an England Journal Science papers. But if you look at most cancers, like colon cancer has about 100, 120 mutations, okay? A lot, but not so many. The ones that are MSI have thousands of mutations. Okay, so lots of different things for your T cells to, and melanoma is higher also, so, but lots of things for them to recognize. This is basically the same. This is actually from the slides rather than the paper. But if you look at the ones that are green or black, they're all in the tumor shrinkage part. So these people tend to do well, and they tend to do well for, once again, for a long time, whether they have colon cancer or not. And that led to the approval. There's also nivolumab that's approved only in colon cancer. I think actually the response, the benefit is probably a little bit lower. This happened to be probably better than average. Others have not been able to show, but still probably about half of people get long-term benefit. Wow, these are people, and I have seen people get off their sick bed and, you know, and really with minimal toxicity and do very well. And this is sort of the same thing that's already been shown. But, you know, it's kind of like Wall Street. 3% of people get all the benefit. 97% of the people, what about the rest? And this is what I spend most of my life working on when I'm not seeing patients. And so how do we help the other 97%? And I'll get to that in a minute because I wanted to talk about upper GI. I can skip this because you've kind of already talked a little bit about this. This is basically, there have been trials. This was called the Keynote 015. Dr. Bong actually, 012, Dr. Bong presented this. But once again, patients with gastric cancers tended to have shrinkage of their tumor. That's okay. Shrinkage is good. But long-term benefit is really what we care about, right? Doesn't matter what the CT scan shows. And what they showed was that a certain small percentage, as was shown, probably about 10% of people, maybe a little bit, had long-term benefit. Now, in those trials, and in fact, that trial led to another trial with pembrolizumab that my colleague Zev Weinberg ran. And what they did is they looked at patients who had that biomarker PD-L1, and they got this drug pembrolizumab, and some people benefited, and that's why it's approved now. The problem is it's only approved in PD-L1 positive patients, which we don't know if that makes a difference. Because there actually was an Asian trial. I believe it or not, there's a drug company called Ono. And so and so that's a Japanese company. And they actually have the rights for nivolumab. And I had them, unfortunately, in January, I had to present this data back to a Japanese group up in San Francisco at our international meeting. But what they showed was that these are patients who had failed prior chemotherapy, and if the ones who got a placebo, they all died eventually. But the key thing is not that this is better, but it doesn't go down to zero. That's really the key thing. This is with nivolumab, which is not approved, actually, for this. They have not been able to do that. And the key thing is that it didn't matter whether they were PD-L1 positive or negative. So for the 3 oncologists in the room, this is actually important. Don't forget about this. You can always get nivolumab off, or pembrolizumab off-label expanded access. So don't forget about this, okay? So, yeah, this is what I was showing. It really didn't make a big difference. They did a little better if they were PD-L1 positive. Okay, so why don't checkpoint inhibitors work for all tumors? How much time do I have left? But anyway, why don't they work? Well, it turns out, remember I showed that first slide, that there are lots of different checkpoints. Something that's this important, okay, that's in other words, keeping your own immune system from attacking your body is going to have lots of layers of regulation. That one thing is probably not going to make a big difference. So it's amazing in some ways that these tumors actually just knocking out one thing with a spike, with a hammer, actually ends up having cancers being, if not cured, perhaps. So it turns out that there are other ones. You probably can't see it. I have it on a better slide here. Ones I'm particularly interested in, GI cancers, are called LAG3 and TIM3. These are actually, we have ongoing trials, mostly, unfortunately, in lung and melanoma. But I did write the colon part, and we're waiting for those results to come back from the colon part with combinations of these. So there's about probably 50 or 60 different molecules in various stages of development trying to hit all these other things that turn off activated T cells, okay? But the problem is that most tumors are not filled with activated T cells. And that's where we're going to try to go from there. Now, sometimes they're excluded, the tumors. These are sometimes called cold tumors. And as Dr. DiCarlo mentioned, with a trial that at least I'm the UCLA PI on, principal investigator on, and I have helped develop, is that there's basically stroma or gristle keeping the cells out. Well, if your tumor is 90% gristle, which pancreatic cancers can be, then it's really hard to get immune cells in, which is why we're interested in things that are not nominally necessarily immunotherapy, but to try to help that. But the other thing is that probably most of the time, they're not recognizing these tumor cells as foreign. So the question is, how do we get cold tumors to hot? And I'm a simple guy. I'm not an immunologist. Tony Ribas is an immunologist. I'm not, but I can understand this. And so basically a cold tumor, CD8 is a stain. This is a marker that's found on those killer T cells. Okay, and if you look on a cold tumor, basically, and brown is the stain. We have a pathologist in here. Brown is always means there's something there, right? And so if you look, the blue is kind of a counter stain. I don't know if you can see this at all. I certainly can't see the red thing there. But there's no brown, okay, 0.03%. This is actually something called cobimetinib. There are probably other ways, combining chemotherapy, targeted therapies, radiation perhaps, viruses we'll talk about, trying to get lots of these T cells in there, okay? So one way is actually vaccination. Remember we talked about vaccinating against human papillomavirus. Please vaccinate your kids against human papillomavirus. I agree with that, even though we're in California. Okay, all right. Please vaccinate. I mean, this is horrible. These diseases are horrible. Head and neck cancer I don't take care of, but it's horrible. Cervical cancer, at least we generally pick that up. Anal cancer, not a lot of fun for the patient, even though we do really well with it. Okay, it is not a government conspiracy, but instead it just helps your kids. But basically the question goes back, in effect, vaccination. And what we want to do is stimulate that innate immune system. That's the one that says, hey, there's something wrong here, and then stimulates the T cells, gets them to recognize it, what's called presents the antigens, and brings them in. It's sort of like calling the police, okay? If the alarm is off, you can't call the police. This is basically turning the alarm on. There are a number of ways you can do this. Actually, we originally thought that chemotherapy was going to be bad with immunotherapy. You're going to tone down the immune system, which sounds way oversimplified even for me. And actually those papers that we just presented last week showed that chemotherapy plus immunotherapy actually worked and was better than chemotherapy alone. Radiation therapy is really interesting. Do we have any radiation oncologists here? They're all, well, we can talk badly about them now, but any surgeons here? Oh, damn. And so anyway, excuse me, I guess I'm being recorded. You can cut that out, right? And so oh, it's live, great. And so anyway, but radiation actually, once again, by killing cells, or chemotherapy by killing cells, I don't know about surgery, but killing cells may expose these antigens, these signals to the immune system. We'll talk about viruses. There are a number of things we'll talk about, particularly I've been doing work and running trials with actually injecting viruses directly into tumors, there's something which I just love the name STING, which stands for stimulator of interferon genes. It's basically like a bacterial infection. It's what happens downstream of a bacterial infection. And we can inject, it's your body's signal, hey, there's a bacterial infection. We can inject those. And toll-like receptors are also similar to that. And they're really, really interesting trials with this. Other drugs that don't cure patients, like signal transduction inhibitors, may also do this. And also talk a little bit about the microbiome, which in effect is like bacterial infections, and we'll talk a little bit about that. And, well, and I think that these only work because if you call the alarm, if you turn down the alarm, and the police shows up, but the police get told to go away, don't worry, everything's okay, that's still not going to work anyway. So I think you need all of these together. Okay, so William Coley actually is considered to be the founder of immunotherapy. I love this picture. And so this was I think it was in the late 1800s. And what he did is he noticed that some people who had infections who also had big tumors, and remember, they didn't have CT scans, so they had to be visible tumors, that when they had infections, they melted away. And then what he did is he ground up pus, basically, bacteria, and injected it into tumors, and ended up having some people actually got better, though it's hard to tell exactly what was happening. On the other hand, that kind of got lost in the mists of history but you know, in some ways what I'm talking about, also I just love this. It looks, don't they look very similar? And so I was thinking, I said, gosh, I know I've seen this someplace before. But anyway, but it's all about the same time. And so the question is, you know, can we, in effect, replicate that? Is this important? And we're actually almost in some ways going back to this. So one way is our viral therapies. And there's already one virus that's approved for the treatment of cancer, and it has the easy name of talimogene repvec. Okay. And so we also called TVEC to its friends. And so, and this is a virus that's already approved in melanoma. And so what it is, it's a modified herpes virus. It's a virus that's been sort of defanged, and also it encodes, because it's been genetically modified, so that when it replicates in the tumor, it doesn't replicate very well, that it actually makes an immune stimulant called GM-CSF. And so, and this has been approved, and this is of course done by advertising people. But basically the idea is to kill cells there. Also, because viruses are one of the things that T cells are supposed to recognize, stimulate the innate immunity, get those T cells in effect, turn cold cells hot. Okay, so this is approved in melanoma already. Now, Tony Rebus, to go back to him, Tony published the first clinical paper in Cell, of all things. And what they did is they combined a PD-1 inhibitor, which I think was pembrolizumab, and together with TVEC in melanoma. And what they showed, whoops, I didn't show that. Oh, anyway. They showed a very high, did I leave that slide out? Oh, man, I left the slide out. I'm sorry. But basically, an incredibly high response rate. In other words, tumors much, much more likely to shrink away. And I'm not talking about the ones that were injected. I'm talking about the ones that were not injected, meaning that by injecting a virus at the same time, you got your immune system, one, to recognize that these cells were foreign. They were not where they were supposed to be. And you unleash them by giving the checkpoint inhibitor. And in fact, there are two trials that we're running in GI cancers. Actually, I'm running both of them. Don't ask me how we ended up with two trials, but they're sort of similar. And I'm the global principal investigator on both. Both of these have to do with injections directly into the liver. We have a UCLA intratumoral immuno-oncology group, because I think injecting these things into tumors actually probably is the best way to stimulate the immune system. And right now, these will be open. Actually, they've been open. They're going to open again for breast, upper GI, colon, lung, melanoma, though melanoma is very busy, and primary liver cancer. This one with a very similar drug called atezolizumab is in triple-negative breast and also for colon cancer. So, unfortunately, that is not something that can be done outside of UCLA. This is not the easiest thing in the world to do with biosafety. What about other intratumoral injections? Well, there are other things basically that have to do, they're called PAMPs, pathogen-associated molecular patterns. These are things that basically your body recognizes. Your body can't grow out pus and say, oh, it's Staph aureus. That what it is that the body recognizes certain patterns, such as having DNA where it's not supposed to be, or patterns in the bacterial wall is saying, hey, there's an infection going on. Okay, this is all part of the innate immunity. And as I mentioned briefly before, STING and also toll-like receptor 9, TLR9. TLR actually overlaps with autoimmunity in GI, with inflammatory bowel disease. And so, but anyway, these are really, really interesting. And there's some actually the TLR9 data, which was just presented last week in patients with melanoma who'd failed a PD-1, had about a 20 to 30% long-term benefit with the combination. So this is really, really exciting. So stay tuned to this. Now, what did we talk about? We talked about bacteria. And I was at a meeting immediately following ACR last week. And the question is that, well, where are we exposed to bacteria? Well, we're exposed to bacteria if we get an infection, but we're also exposed to bacteria in our skin, and we're exposed in our bowels. And particularly in our bowels is sometimes called the microbiome. And so that is kind of, a portmanteau, I think that's what it's called, like genome or transcriptome. This is your microbiome. And so these are the commensal bacteria, and there are actually more of them than cells in our body, though they're much smaller. So I have seen in the lay press that they weigh more than the rest of your body. So unless you're really strangely built, that's not true. But the cells are small, so there actually may be more of them than regular cells in your body, if that makes sense. And this is greatly affected by what we eat or drink. This is also affected by, maybe affected by exercise, and this may be the link. I'm originally a prevention guy. That when I was a gastroenterologist, my research was in prevention of cancers, which is somewhat different, but related, and maybe the link between diet and disease. Okay, so let's talk about diet and recurrence. Oh wow, this is CME, so don't you didn't see that. I do actually, work out in the field, and so I am partial, I have to admit, to the Egg McMuffins. But anyway, so there are two parts, and people conflate these. There definitely is a relationship between diet and getting cancer. Okay, that's probably different. Now, people can be on the entire carnivore meat diet, for example, and most of them still don't get cancer. But on the other hand, to me, what's always been fascinating and really interesting is that there's also a relationship between diet and recurrence. So recurrence means the patient, and this is in colon cancer, which is mostly what I work in that in colon cancer, patients, they often get found, they may get found early by the gastroenterologist, hopefully prevented by the gastroenterologist by taking out polyps. They tend to be found early, and then they go to surgery, and most people with colon cancer are cured, but not all. That's what keeps, unfortunately, us in business. I'd much rather be doing something else. And so the question is that why do some people recur? They get staged, and they all look the same, and other people don't. And one of the thoughts is that it may be an immune thing. Some is that maybe some have cells that are in other places, but maybe it's the immune system that's keeping them in check. Because what's really interesting is that patients who eat a healthy diet actually have a lower recurrence rate. That means, to me, that those cells are there somewhere, but somehow your immune system is keeping them in check. People who exercise more actually have a lower recurrence rate as well. These are not randomized trials. These are retrospective, but they're really good retrospective trials from like Charlie Fuchs's group or Jeff Meyerhart at the Dana-Farber, looking at these very large adjuvant trials, very granular, looking at, and basically patients who ate a prudent diet had a lower risk over time rather than people who ate which was charitably called a Western diet. Now, what's even more interesting now to me is what happens in those patients who get PD-1s. Because remember I said that, or immune therapies. Most people don't benefit from them. Even in the diseases where they do benefit, most people still don't benefit once you get beyond that really small percentage of microsatellite and unstable patients with lots and lots of. So there were 3 papers published in Science, which is one of our most prestigious, probably one of the 2 most prestigious, actually, scientific journals, basic science journals. And there were 3 groups, one in Paris, one in Chicago, one in Houston, all showed the same thing. So they looked at people who had diseases that have a chance of responding, kidney, lung, melanoma, okay. And they looked at them and they showed a couple different things. One, the bacteria in people who responded, who benefited, was different than those that didn't. Okay, that's really interesting. How do you change your bacteria? Well, it's whether you eat lemon bars or not, actually. And you can change that, though they were really good, actually. Whoever told me they were really good, they are really good. And so anyway, so that's actually really interesting. And I think I can see that. It's hard for me to see here, but one of these graphs is actually, and they had different bacteria in them. The other thing that was really interesting is that the other thing that can change your microbiome is whether you get antibiotics or not. Now look, if you need antibiotics, you should get antibiotics. But we do use a lot of antibiotics. And that patients who got antibiotics, these all had lung or a renal cell, anyway, or bladder. And the patients who got antibiotics are in red, and the patients who didn't are in black. That is a major, all got the same drugs, all had the same thing. So we probably should only use them if necessary. And then kind of the neatest thing, and all 3 groups showed this, is that they took stool from So they took stool from responders and non-responders, and they put them in mice, lucky mice. And so what they did is they cleaned the mice out, okay. They purged them and they made them so they didn't have any bacteria. And then they fed them stool from either responders, lunch is over, I'm a gastroenterologist, come on. And so they fed them stool either from, and they actually do fecal transplants for C. diff. And so my first paper was actually on C. diff. I knew about this before it was cool. It was kind of a curiosity. But anyway, So what they did is they put bacteria into the mice, whether from responders or non-responders, and then they put tumors in the mice. And then they gave them these drugs. And the ones who had stool from responders responded. And the ones that didn't had stools from those that didn't respond also didn't respond. So not only was it different between the responders and the non-responders, but you could actually take them and put them in mice, and you recapitulated, you were able to see the same thing over again. This is something that's very powerful. And so, but we're not there yet. We're just asking the questions. So, all right, so I'm going to then switch a little bit because it also has to do with bacteria or personalized vaccines. This is a national trial that I'm running. But there are at least 2 other similar ones. And the idea is that bacteria really, really cause an immune response. Has anyone ever been septic here? Okay, you know what that's like. If you've ever been septic, you have shaking chills, you're sick. And so one of the things that really can cause this is listeria. Listeria is a bacteria. I've also had family members almost die from this. So that's why it's kind of strange to be using this. And this is a study in colon cancer where we're taking the tumor and we're sequencing it. And then we're taking the person and we're sequencing them and saying, what are the 120 different mutations? We're taking the top 40, I love that, like top 40. And then we're putting them into the bacteria, giving them to the patient, in effect vaccinating the patient with their own mutations, trying to see if we can get that. So there are at least 2 other companies. The trial I'm running is called Advaxis, but there's 2 other companies that are doing very similar things. What about other trials at UCLA? How much more time do I have?
5 minutes.
5 minutes, okay, good, I'm close to the end. You already mentioned the pegylated IL-10. This works by a different way. So this is basically, it's not a checkpoint, but once again, it stimulates the T cells. So when we gave pegylated IL-10 and we looked in the blood, that we saw a huge increase in the number of T cells that were circulating that we hadn't seen before we started. And in fact, and this is what we ended up seeing, was that some people, pancreatic cancer is a really bad disease. Of the 3 things, not that upper GI is good, not that any of these diseases are good, but pancreatic cancer probably is the worst of the group. And we still have people alive who are on this. And this is in second, actually most of these people had several prior therapies. And in fact, I think as you alluded to, I presented this data actually at the European GI meeting, is that some people, in fact, about half the people are still alive a year later. And so, which is really unusual. Now, maybe we just were lucky and we just happen to have really good patients who are somehow different. This has led to a phase 3 trial that is open here. And also that other trial, I think you had also mentioned with the anti-gristle, the anti-hyaluronan antibody, or pegylated hyaluronidase, is also open also here. So you do not have to drive down to see me. As much as we like to see people, you do not have to drive down to Santa Monica. So to finish up, we are hopefully on the verge of conquering GI cancers. And I would not have said this 5 years ago. In fact, I would have figured I would spend the rest of what little remains of my career actually tweaking things and kind of moving things around with signal transduction inhibitors, those things that affect the growth, and making fairly minor benefits. But instead, here we have that at least in some people really benefit an awful lot. And the question is, how do we help the rest? How do we help the 97%? I think that's really important with the environment, meaning not the environment, that beautiful environment out there, but the environment inside, because true beauty is inside. And so I think that's really important. And only by doing trials, people ask, well, why should I go on a trial? Well, that's how, 1, you might get better therapy. 2 is that, and you don't necessarily have to leave town, but 3 is that you also move the ball down the field, okay? And we're fortunate, and I think this is really true, that we're fortunate to work with talented oncologists here in San Luis Obispo, as well as our TRIO network around the country. We could not do these trials without, they could not all come to Santa Monica or Westwood, and nor should they, is that we need this to be a nationwide effort. And TRIO US is part of that nationwide network. And in fact, TRIO US is part of TRIO Global, which is actually a global network that has moved some of these trials, hopefully, once again, further down the field. And so if there's benefit, it's not just because of people in places like Los Angeles, it's because of people right here. Well, thank you very much.